This is the first part of the cardiac drugs. So we're going to start off by looking at the function of the nephrons in the kidney. So what you can see here on the picture on the right is that there's an extensive network of capillaries in the red and in the blue surrounding various elements of the nephron. So the nephron is in the beige, right? So you've got both cortical nephron and juxtamedullary nephron. We won't go into the differences and the similarities between that. But basically what happens is whatever is in the beige nephron, the beige area, is what will eventually get collected up to form urine. Right? The diagram on the left basically gives you the three main functions of the nephron in actually filtering and producing the final product of urine. So the first function of the nephron is called filtration. And what we see in filtration is that the solutes, electrolytes, nutrients, what have you, basically leave the capillaries, the glomerular capillaries, and enter into the Bowman's capsule. Right? The Bowman's capsule, as you can see over here, is continuous with the renal tubule. So whatever goes into the Bowman's capsule then enters into the renal tubules. In the renal tubules, it undergoes reabsorption. And you can see here that 99% of the water, electrolytes, nutrients, and other solutes that are filtered return, or are reabsorbed back into the peritubular capillaries somewhere along the tubules. And then the last function of the nephron is secretion, and that's an active process. And in secretion, what happens is water and any solutes leaves the capillaries again to enter into the tubules. And then it gets collected, and then it gets excreted as urine. So again, just to give you the basic function of the kidney, because this relates to the effects as well as adverse effects of diuretics, right? So basic function of the kidney is to basically cleanse extracellular fluid, namely blood, and to balance extracellular fluid in terms of the volume of fluid that's present in the extracellular fluid compartment, as well as the composition, so the amount of electrolytes, and as well as the acid-base balance. Metabolic waste and foreign substances are also excreted in through the tubules and leaves the body as urine. So the diagram on the right basically just shows you the different structures found within the nephron. So the first one is the glomerulus, the bundle of capillaries within the Bowman's capsule. And then, as I said, the Bowman's capsule is then continuous with these four parts of the tubule. So the first one is a proximal convoluted tubule, the loop of Henle, distal tubule, and then finally the collecting tubule, where it basically is collected up and goes into the ureter, and then the bladder, and then the urethra. At the various levels of the nephron, you can see the function, right? So the function of the glomerulus is mainly filtration. Function of the proximal tubule is largely reabsorption with some secretion. And then you've got reabsorption and secretion going through the other parts of the tubule itself. So what we're going to look at is we're going to look at what happens when reabsorption is altered at the various different levels. Because remember, reabsorption is when solutes and solvents leave the tubules and enter back into the capillaries. So what happens to diuretics is that the mechanism of action is to basically prevent reabsorption of sodium. You can see here that sodium is the main ion that's involved in reabsorption. And when sodium is blocked, reabsorption of sodium is blocked, then reabsorption of water is also blocked. And so if you decrease reabsorption of sodium and water, what it means is that it increased the amount of sodium that stays in the tubules, as well as increase the amount of water, and therefore increases the amount of sodium that leaves in urine. And that also will be related to increasing the amount of water that leaves in urine. So if you have more sodium and water leaving in urine, then you have less sodium and water in the blood, and so blood volume decreases, and therefore blood pressure also decreases. So diuretics, as you can see here, the two major applications of diuretics is for treatment of hypertension and to also get rid of edematous fluid, right? So as a result of using diuretics, as I said, urine output is increased, and there's a decrease in plasma volume as well as blood pressure. However, there are some adverse effects. So one of the adverse effects is when the blood volume drops down too much, it can end up with hypovolemia, it can end up with dehydration, and the patient can also end up with hypotension. Because sodium is one of the ions that is altered in terms of its reabsorption profile, you can end up with electrolyte balances, as well as not only of sodium, but of potassium and of other anions, of other ions. And because acid and bicarb is one of the is also two solutes that are adjusted within this process, it can also lead to an acid-base imbalance. Now, what we're going to look at now is we're going to look at the extent of diuresis. So what I'm going to do is I am going to use a highlighter and highlight the proportion of sodium and therefore water that gets reabsorbed at different parts of the renal tubule, right? So again, reabsorption is the return of sodium and water and other things that were filtered back into the blood. So you can see here at the level of the proximal convoluted tubule, 65% of sodium is reabsorbed at that time. At the level of the loop of Henle, you've got 20% of sodium and water reabsorbed. At the level of the distal convoluted tubule, it's 10%, and at the level of the late distal convoluted tubule and collecting duct, it's 1 to 5%. Now, conveniently, there are drugs that are specific to blocking reabsorption at each of these points. So we're not going to talk about mannitol today, but we're going to focus our attention on the other three sites, right? So what you see over here is that the extent of diuresis decrease across the nephron. That means the earlier that it comes across in the tubules, the more sodium is reabsorbed, right? So you've got 65 first, then you've got 20, then you've got 10, and then you've got 1.5. And so, as I said, you can selectively block reabsorption at each of these phases. So drugs that work early in the nephron have the largest diuretic effect, and therefore inhibition of reabsorption earlier on at the PCT leads to more diuresis than, say, reabsorption later on at the distal convoluted tubule. In terms of numbers, what happens is over the course of a day, a normal kidney will produce 180 liters of filtrate a day. And as I said, 99% is normally absorbed. So typically, a person will produce 1.5 to 2 liters of urine, right? If only 1% of solute reabsorption is blocked by a diuretic, it increases the amount of urine produced by 1.8 liters. right? So if you actually work it out, if you block 3% of solute reabsorption, it would end up producing 5.4 liters of urine, which converts to about 12 pounds. And if you do it in a day, in 24 hours. So this is the reason why diuretics are used as a weight loss product. But as I said, it has adverse effects of causing acid-base imbalance, causing electrolyte imbalance, causing dehydration, hypertension, and hypovolemia. So it's not a good strategy for quick weight loss because it might lead to more serious adverse effects. Going back to this, we're going to look at these three groups of drugs. So the first group of drugs we're going to look at is called a loop diuretic or high ceiling diuretics, right? You can see over here it's got a rapid onset, right? So IV, it sets in 5 minutes, and orally, if it's orally administered, it takes an hour, and it leads to the greatest amount of diuresis possible out of the three that we're going to talk about. So it works on the loop of Henle, and so you've got here what the normal loop of Henle is. So it concentrates urine, it causes water reabsorption, and as well as sodium reabsorption, right? So this is the site of action, the ascending loop of Henle. Remember, this is the descending, and this is the ascending loop of Henle. So mechanism of action, it blocks sodium and chloride reabsorption, and it also blocks insulin release. And because it blocks insulin release, it causes an increase in glucose levels. It also increases uric acid levels. All right, so it's used to treat hypertension and edema. And as I said, the adverse effects of diuretics are directly linked to its mechanism of action. So if you look at this, because it decreases sodium reabsorption, what happens is there might be less sodium in the blood, so you end up with hyponatremia. Because it decreases chloride reabsorption, you can end up with hypochloremia as well. You can end up with hypokalemia, a drop in potassium levels, and this is a problem in cardiac patients, and we'll talk more about that later. And because it blocks water reabsorption, you can end up with dehydration, hypovolemia, and hypotension. Because it increases glucose levels, you can end up with hyperglycemia. Because it increases uric acid levels in the blood, the patient can end up with hyperuricemia. So the only thing that's not explained by the mechanism of action is ototoxicity, right? So changes in hearing, and for furosemide, which is the main drug loop diuretic used, it's often transient. All right, let's look at the contraindication. So the contraindications for use with high ceiling or loop diuretics are these. So first of all, digoxin and lithium. So these drugs need a stable sodium and potassium levels, and we talked about how the excretion of sodium follows the excretion the excretion of lithium follows the pattern of excretion of sodium. So if less sodium is reabsorbed, then less lithium is excreted, and then it basically increases the doses of lithium in the body. In terms of non-steroidal anti-inflammatory drugs, it blunt the diuretic effects, and you have to actually be careful when used with other antihypertensive agents, because it might actually increase the risk of adverse effects. Be careful with use with pregnancy and lactation, because it might have effects on the fetus or the newborn child. And again, you don't want to combine it with other ototoxic drugs, because it then increases the risk of ototoxicity. Second class of drugs are thiazide diuretics, and thiazide diuretics work on the early distal convoluted tubule. And at that level, normally about 10% of sodium and chloride are reabsorbed. And so you see here with the distal tubule, you've got here the normal function is reabsorption of sodium, water, and bicarb, and secretion of these ions and drugs. Right? So diuretic effect, less diuresis than loop diuretics. If you go back, you can see here that at the level of the loop of Henle, about 20% of sodium and chloride are reabsorbed compared to only 10% in the early distal convoluted tubule. So site of action over here. Mechanism of action exactly the same as loop diuretics, but it's not effective when the glomerular filtration rate is low because it needs a good amount of fluid to be filtered from the glomerular capillaries into the Bowman's capsule and into the tubule for the thiazide diuretics to work. So basically, it needs it can only be used with in people with normal or healthy kidney function. Therapeutic uses, same as loop diuretics. Adverse effects, same as loop diuretics, but there's no hearing loss. There's no ototoxicity. So contraindications is the same as loop diuretics, but without the contraindication with other ototoxic drugs. So again, thiazide diuretics, very similar to loop diuretics with a couple of exceptions, right? No ototoxicity, and it needs to be used with in people with normal or fairly healthy kidney functions because it can't be used when the glomerular filtration rate is low. Third class of drugs are called potassium-sparing diuretics, and they also work mainly as aldosterone antagonists or aldosterone receptor blockers. Now we'll talk about aldosterone later on. So aldosterone is part of the Renin-Angiotensin-Aldosterone system, and it's the second A over here. And what happens is the receptors for aldosterone is found in the late distal convoluted tubule and in the collecting duct, right? So this is what happens. So diuretic effect, less than thiazide diuretics, but there's no loss of potassium. So it's safer to use with cardiac patients. So not only with people with high blood pressure, but also people that have cardiac issues. Mechanism of action, as I said, it blocks the aldosterone receptors. And so this is how it works. So if you look down in the diagram down below, you've got here, this is the epithelial cell. Right? This is the tubular fluid, so this is in there, and this is the capillary side. And so what happens is that these drugs work on blocking sodium re-entry into the cell and therefore into the blood. So it blocks sodium reabsorption. And when it blocks sodium reabsorption, it basically stops potassium from leaving. And so what happens is the level of potassium increases inside the cell, and so the level of potassium in the blood also increases. And you can see over here that the adverse effects is an increase in potassium levels. Now, because aldosterone is a hormone, one of the adverse effects is it can also cause other endocrine effects. So you can see over here, the mechanism of action is by blocking aldosterone receptors, so it increases secretion of sodium while retaining potassium. And so the use is pretty much the same as loop diuretics, but it's also used in patients with heart failure because it maintains the level of potassium. And it's also used in people who produce too much aldosterone, right? So primary hyperaldosteronism is when there's too much aldosterone being produced, and so it's used to actually block the effects of aldosterone. Right? Contraindications, you've got thiazide, other diuretics, so thiazide and loop diuretics, although sometimes it is used in combination with that, but with an adjustment in dosage. Also be careful when using other drugs that cause hyperkalemia, because then that increases the risk, obviously, of hyperkalemia. And cautious when used with ACE inhibitors. And the reason for that, we'll actually explain later, is because ACE inhibitors are also working on the same renin-angiotensin-aldosterone system. All right, so you've got the three types of diuretics here, and we're going to move on and talk about the renin-angiotensin-aldosterone system. So over here, again, just a review. So renin is released by the kidney over here, travels in the blood, where it basically converts angiotensinogen that's produced by the liver into angiotensin 1. And then angiotensin 1 floats in the blood until it encounters the enzyme angiotensin converting enzyme, or ACE, which is largely produced by the lungs, and the ACE enzyme converts angiotensin 1 to angiotensin 2. And it's angiotensin 2 that has the effects. So one of the effects of angiotensin 2 is to secrete aldosterone. All right, so this is the flow chart of the renin-angiotensin and aldosterone system. So what I'm going to do is I'm going to flip to the chart on the left and look at angiotensin, right? So as I said, one of the functions of angiotensin is to secrete aldosterone, right? And what aldosterone does is it increases reabsorption of sodium, and increases the total body volume of sodium, and it therefore increases water reabsorption, right? Now, the other thing with angiotensin, if you actually break it down, angio means blood vessels, tensin is pressure. So what happens with angiotensin is it causes an increase in blood pressure. All right, directly through vasoconstriction. You can see also here that it also increases ADH secretion. So these three mechanisms here, I'm going to use a different colored pen. These three red boxes here work to actually increase blood volume and therefore work to increase blood pressure, right? And it restores the blood volume and blood pressure, because if you look at what triggers the renin-angiotensin system, the RAAS, is that it's triggered when plasma volume goes down, and it's also triggered when plasma sodium concentration goes down, and it's also triggered when blood pressure goes down. So when these three mechanisms, when these three things happen, it triggers the RAAS system, and that leads to an increase in blood volume and blood pressure back to normal. Now, having said all this, what happens is drugs can be used to actually block the renin-angiotensin-aldosterone system at various different points, right? And the reason why you want to actually block it is to actually decrease blood volume and therefore decrease blood pressure, right? Because as I said, the result of activating the renin-angiotensin-aldosterone system is to increase blood volume, which then increases blood pressure. All right, so again, if you activate the effects of the RAAS, when you activate it on blood pressure and blood volume, is to increase both, and so when you inhibit it, you decrease both, right? The effect of the renin-angiotensin-aldosterone system on electrolyte imbalance is that it causes an increase in sodium in the blood, and it decreases potassium and hydrogen ion levels in the blood. And so when you inhibit it, it decreases sodium levels in the blood, and it increases potassium and acid levels in the blood, right? Angiotensin, because of the name, it leads to vasoconstriction, and then that directly then increases blood pressure. And so if you inhibit it, it causes vasodilation, and it decreases blood pressure. It also decreases release of aldosterone, and aldosterone then leads to a decrease in sodium water reabsorption, which then causes a decrease in blood pressure and blood volume, and it decreases it decreases potassium and hydrogen ion secretion. And so secretion is when things move from the blood to the tubules, and so it increases the levels of potassium and hydrogen ions in the blood, right? And you can see here when the RAAS system is activated over a long period of time, it can cause cardiovascular effects, and these are the cardiovascular effects that it causes. When we look at drugs that act on the RAAS system, you can see that it can act in 3 different ways. So we're going to look at these 3 drugs. So the first set of drugs we're going to look at is we're going to look at ACE inhibitors. So ACE inhibitors basically block the angiotensin converting enzyme. So they work over here, right? They stop angiotensin 1 from being converted to angiotensin 2. The second lot of drugs are called angiotensin 2 receptor blockers. So they bind to the angiotensin receptors and they block its effect. So when you block the effects of the angiotensin receptors, you decrease the secretion of aldosterone, you decrease renal vasoconstriction, and you decrease systemic vasoconstriction, right? We're going to go to the next slide to explain how really blocking at the level of the ACE inhibitors or at the level of the angiotensin 2 receptor blockers are essentially the same thing except for one facet, and that's going to be the subject of the next slide. And then the last point that we can actually block the RAA system is by blocking the aldosterone receptor. Right, and that was the subject of the 3rd class of diuretics, the potassium-sparing diuretics. And when you block the aldosterone receptor with an antagonist, it basically affects the sodium-potassium exchange and causes more diuresis while retaining potassium levels. So we're going to look at the first 2 groups of drugs because they're essentially the same. So if you look at the uses, same as ACE inhibitors. If you look at adverse effects, same as ACE inhibitors with one exception. If you look at the contraindications, same as ACE inhibitors, right? So the only thing that's different is really the mechanism of action as well as this but no cough thing. All right, so let's look at that. So mechanism of action for ACE inhibitors is to inhibit conversion of angiotensin 1 to angiotensin 2, so it prevents the effects of angiotensin 2. Mechanism of action of angiotensin 2 receptor blockers is to inhibit receptor activation of angiotensin 2 and gives you the same results, right? Thus preventing the effects of angiotensin 2. And I've deliberately used the same phrase just to highlight that the effects are largely the same, okay? And so you've got its uses over here, and then you've got the adverse effects, right? Vasodilation and severe first dose hypertension is because it inhibits the effects of angiotensin 2. And remember, angio blood vessels, tensin pressure. So it causes a reverse of that increased blood pressure, which can lead to vasodilation and first dose hypertension. It can also cause fetal injury, so you have to make sure that the person taking it is not pregnant or doesn't have the potential to be pregnant. And it can cause an increase in potassium levels through inhibition of sodium-potassium exchange. And so the only weird side effect is this cough, right? And in order to explain why ACE inhibitors can lead to a cough, whereas angiotensin receptor blockers does not, you look at the diagram or the schematic that's in the top right corner. All right, so you've got angiotensin being converted to angiotensin 2 with the use of ACE, right? Now, angiotensin converting enzyme is also known as kinase 2, right? So ACE is also known as kinase 2. So what happened was a different scientist found out about it and named it kinase 2 based on its function. And the function of kinase 2 enzyme, which is the same as the ACE enzyme, is that it breaks down bradykinin into an inactive product, right? So what happens when ACE inhibitors are given is that inhibits the ACE enzyme and also inhibits by its very nature the kinase 2 enzyme. And so if the kinase 2 enzyme or the ACE enzyme is inhibited, then you increase the amount of bradykinin. And you can see here, when you increase the amount of bradykinin, then it causes vasodilation, same as inhibition of angiotensin 2, but it also causes cough. And this cough that it causes is a persistent, dry, non-productive cough. And so it, for some people, it can actually be so annoying that it impairs their ability to do their job well, or it impairs people's perception of them as they're actually doing their job, right? So again, this is the dry, persistent, non-productive cough is one of the main reasons why people would switch from an ACE inhibitor to an ARB. Now moving on. And again, I'm not going to talk about aldosterone receptor blocker because I've talked about them within the context of the potassium sparing diuretic. Now moving on, this slide is an introduction, is a explanation slide, and what this slide does is it does two things. First of all, it highlights the importance of calcium, right? So when calcium goes into the myocardial cells, what happens is it causes an increase in heart rate through activation of the SA node. It increases activation of the AV node, so it increases conduction velocity, and on the muscle cell itself, it causes an increase in force of the myocardial contraction. All right, you can see in the top right diagram, you can see here that calcium is involved in this plateau that's seen in the action potential of the ventricular cardiomyocytes, and this calcium entering into the cell is responsible for the prolonged contraction of the ventricular cardiomyocytes. Now, calcium doesn't just work on the heart. When calcium enters into the smooth muscle, it can also cause contraction of that smooth muscle, right? So you've got here the effects of calcium on the heart. You've got here the effects of calcium in the smooth muscle. And again, you don't have to know all the ins and outs. I just wanted to show you that when calcium goes into the cell, you've got a series of changes, and that leads to smooth muscle contraction. Now, the diagram on the left, I basically also included because it shows you that beta receptors in the heart, so you have the beta 1 receptors in the heart, is linked to calcium channels in the heart. So if you block beta receptors, right? So if you give someone beta blockers and you give someone calcium channel blockers, it may actually increase the therapeutic effects, but also can lead to an increase in the adverse effects, right? Because it works via the same pathway. So what we're going to do now is we're going to look at what happens when calcium channel blockers are added, right? So the first half, the top half, is what happens normally when there's no calcium channel blockers. So without calcium channel blockers, calcium channels stay open, calcium enters into the cell, and it causes contraction and an increase in contractility, heart rate in terms of the heart, and it causes contractions of the smooth muscles. So it causes vasoconstriction in the peripheral arteries. Now, in the presence of calcium channel blockers, calcium doesn't enter into the cell, and so what happens is it reduces its effect on cardiovascular arterioles and arteries. So it causes vasodilation, and that means blood pressure drops. And because it causes vasodilation, there's more blood going to the heart, right? Because instead of blood being able to go through an arteriole that big, it can go through an arteriole that big. So there's more blood going to the heart, and so coronary perfusion increases. Now we're going to look at the effects of the heart, because it inhibits it leads to an inhibition in myocardial contractility. So it slows down heart rate, it slows down pacemaker activity, it slows down AV node conduction, right? And so you've got an effect there. Okay, now the thing with calcium channel blockers is because it can drop blood pressure, you need to actually take a set of vital signs prior to administration, not only blood pressure but also heart rate, and you need to have, in case of severe hypertension, need to be able to administer epinephrine. There are two classes of calcium channel blockers. So you've got dihydropyridines, and then you've got those drugs that are not in the dihydropyridine category, so they're called non-dihydropyridine. So you've got nifedipine, and you've got verapamil, which is the drug of choice in each of the categories, right? So you've got over here contrast between nifedipine and verapamil. So and what you see over here is that nifedipine has effects on cardiovascular arterioles and arteries, but with minimal effects on the heart. Right? So basically it causes arterial vasodilation, and it really doesn't cause any effects on the heart, right? And so if you look at the cardiac effects, when you look at dysrhythmias, it doesn't have an effect on dysrhythmias, but it also have no cardiac adverse effects, right? So that's what happens. It also incidentally doesn't cause constipation, and because it doesn't have an effect on calcium channels on the heart, it doesn't affect AV block or doesn't have any interactions with beta blockers. Okay, verapamil has the same effect as nifedipine on the blood vessels, right? So same adverse effects as nifedipine on blood vessels, but it also has other effects because it does work on calcium channels in the heart. So if you look at that, so I've highlighted all the boxes are to highlight the differences between nifedipine and verapamil. Because it has an effect on the heart, it can cause reduced automaticity, it can reduce AV conduction, and it can also reduce cardiac contractility. All right, and so it's used not only for hypertension and to relieve symptoms of angina, but it's also used for dysrhythmias because it regulates and slows down the heart rate. All right. Adverse effects, exactly the same as nifedipine, with added effects, adverse effects on the heart, right? Because it can actually make the AV block worse. It can cause heart failure, and it can make heart failure worse, and it can make the sick sinus syndrome worse as well. All right. So again, with verapamil, you have those added effects on the heart that nifedipine does not. And so you have to actually decide whether you're actually treating a person with high blood pressure with or without cardiac complications. Now the next few slides are on high blood pressure and antihypertensives. So you've got over here just the classifications of hypertension. And you can see here that hypertension has no identifiable cause, mostly with primary hypertension. With secondary hypertension, there is an identifiable cause, and so it's possible to treat, if it's possible to treat the primary cause, secondary hypertension can actually be cured, right? So you've got the various goals of hypertension. So again, you've got the blood pressure goal over here. And what happens when hypertension is untreated? It can lead to heart disease, kidney disease, and stroke. So just a review of blood pressure control. So blood pressure is basically the pressure of the walls of the blood vessels back onto the lumen, and so it's determined by arterial pressure as well as cardiac output. So some systems that help regulate blood pressure is the sympathetic nervous system, that helps by measuring the pressure within the blood vessels. And then you've got the Renin-Angiotensin-Aldosterone system that we talked with at length before. And then you've got renal regulation of blood pressure, because obviously when more urine is produced, there's less blood, and therefore blood pressure drops. Whereas if less urine is produced, you've got more blood volume and blood pressure increases. So just this is an overview slide, basically just giving you an overview of the different drugs that are used to actually treat high blood pressure. So you see over here, some drugs act directly on the vascular smooth muscles. So those drugs are calcium channel blockers that we talked about before, vasodilators that we're going to talk about next week. You can also choose to alter the effect of the autonomic nervous system, largely through the sympathetic nervous system. So you can block the sympathetic nervous system either globally or directly through blockage of the beta-1 receptors in the heart or the alpha-1 receptors in the blood vessels, right? In the renal system, you can choose to affect what goes on in the renal tubules with the use of diuretics. On the beta-1 receptors on the glomerular cells, that's the one that is involved in renin secretion. And so if you block that, you decrease renin secretion and you decrease activation of the Renin-Angiotensin-Aldosterone system. And that brings us to the Renin-Angiotensin-Aldosterone system. You can choose to block it at these three various sites. And again, we've talked about most of it. We haven't talked about vasodilators. And as I said, we're going to talk about that in the next lecture. So in terms of drug treatment and risk modification, you've got here just the various steps, right? So step 1 is lifestyle and dietary modifications. So again, not very exciting. So encouraging the patient to actually lose weight, to take up exercise, to quit smoking, and to actually modify their diet, right? And then step 2 is when the dietary modifications don't quite work, and so you start on drug therapy. So you've got here just the various drugs that can be used, right? And then step 3 is when you add or change the drugs. So substitute with either drug from a different class, or you add a second drug from a different class. And then step 4 is basically adding more drugs from a different class to actually try to bring down the blood pressure by a variety of ways. Now, it's very, very hard to actually get someone to actually start high blood pressure medication and to actually continue with it. And that's why lack of patient compliance is a major issue with high blood pressure, right? And the reason why compliance is very, very hard to actually get is because high blood pressure progresses slowly. The adverse effects takes years to manifest, and there's very, very few symptoms, right? And the drug treatment, as you can see over here, changing lifestyle and other exercise, smoking, dietary habits, is very time consuming and it's very complex. The treatment once you start is chronic, lifelong, and it's also expensive. The other thing is that high blood pressure really has very, very few symptoms because it takes a long time to develop, and there are very few very obvious symptoms. And so what you're actually trying to get a patient to do is to actually take drugs that can have adverse effects when they're feeling relatively well without the drugs, right? So why take the drugs if these drugs cause me adverse effects? Because I'm fine otherwise. So just some ways to promote compliance is to educate the patient on long-term effects of the condition when it's untreated. So cardiovascular effects, renal effects, strokes, teaching self-monitoring. So again, teaching the patient how to actually monitor or take their blood pressure measurement and seeing the effect of the drugs on the blood pressure. That promotes positive feedback and increases involvement, minimize side effects by communicating with health professionals. So again, if there are any adverse effects that come up, that they can actually go back to the health professional so that a different drug can be prescribed. And again, that communication piece with a health professional is very, very important. And then again, simplify the regimen, especially if combination drugs are to be used. So if more than one drug is to be used, maybe find a pill that combines those two drugs that the patient needs to take so that it's less pills for them to take, and also a simple dosing schedule. All right, that's it for now. I'll see you next time.